So the next one up here is chapter 29, the bowel needs. So this one has to do more with the GI system, and the next one does as well. So bowel elimination is the excretion or getting rid of waste from the gastrointestinal system or the GI system. The factors affecting bowel elimination include privacy, everyday habits, age, diet, exercise and activity, fluids, and drugs. Okay? So you're going to see this picture right here on this chapter and the next one. So you need to remember that the GI system starts at the mouth and ends all the way at the anus. Normal bowel elimination, the time and frequency of bowel movements vary between patients, but stools are normally brown, are soft, formed, moist, and shaped like the rectum. We do need to know the details of that when you flush a patient's or change a patient's adult diaper. We need to know these things, okay? They do have a normal odor because bacteria are mixed in the intestines with that, and that is where the odor of bowel elimination comes in. You should observe and report the following to the nurse. So the color of the bowel movements, the amount, the consistency, is it watery, is it loose, is it formed, is it soft, is there presence of blood or mucus, is there a bowel odor, is there shape, the frequency of bowel movements that happen, and complaints of pain or discomfort with this system. Of course, the factors or goals here are going to be that we need normal, regular elimination. It's going to be the goal. Factors that affect stool frequency, consistency, color, and odor are going to be the lack of privacy, habits, so being relaxed and not tense. You know, if you're going to the bathroom in a hospital or care center that you're not used to, then that could be a problem. Also, if you don't have a diet high in fiber foods like fruits, vegetables, and whole grains, then that could create a problem in bowel elimination. Other foods like milk may actually cause diarrhea, or spicy foods or chocolate may actually cause the opposite and cause those diarrhea episodes. Fluids, it also depends on how much they're drinking. Are they dehydrated? What exactly they're doing, and so forth with their fluids. If they're not having any activity and their bed rest from disease or surgery or injury or aging, this could cause huge problems as well. Also, some drugs that are treated for pain and can cause lots of problems with constipation, and antibiotics can cause diarrhea on the other end. Also, disability and aging really affect the normal passage of bowel elimination. Constipation is going to be defined as the passage of hard, dry stool. It occurs when feces move slowly through the bowel. A fecal impaction. Anybody get to see one of these last year? I hope you didn't, but you very possibly could have. A fecal impaction. This is the prolonged retention or buildup of the feces in the rectum. These get so bad, they cause the patients especially our elderly population, tons of pain. The feces are hard and putty-like. You can actually start to see them in their lower back region going up their bottom if they're really bad. Yes, they're underneath the skin, but it can become so hard and impacted in their colon that you can actually see it, and they get so frail in their elder age that you can see the impaction. Okay, so it's not normal. I mean, it happens frequently to patients that are elderly because they have so much problems with these daily habits. Okay, what? So you cannot fix a digital impaction by manually doing it, but a nurse can. I'm going to talk about that. So you may have to assist and so forth, but feces themselves refers to semi-solid masses of waste products in the colon. Peristalsis is the alternating contraction and relaxation of intestinal muscles. And defecation is also known as a bowel movement. It's a process of excreting these feces from the rectum to the anus. Okay? So this is going to be some normal stool shapes and consistencies that you need to report, whether it was formed, smooth or soft, watery or loose and unformed. The nurse does a digital finger exam for an impaction only. Do not do that. You may very likely have to witness one of these, but the digital exam can actually help urge the patient to have a bowel movement as well. So if you're looking at this picture down here, You can see that the nurse inserts their finger about 2 inches or so to try to get the bowel system moving and try to get this this impaction removed. The only thing is that you run a very dangerous risk factor here because we have something called the vagus nerve in our rectal area, and that once it's stimulated, it can really drop the heart rate down, where it can cause people with low heart rates already, which are the elderly, to drop down too low. It can be unsafe. Okay. Diarrhea is going to be the frequent passage of liquid stools. They move through the intestines very rapidly. Diet and drugs are going to be ordered to reduce that. Hopefully, you need to assist with elimination concerns promptly or quickly. Dispose of the stools promptly. Give good skin care, because if they're having frequent stools, their skin is probably breaking down as well. The fluid loss through diarrhea is very significant for the elderly and our patients that are already sick, and so they may get dehydrated from that as well. And please follow standard precautions and blood-borne pathogen. If you've already went into the room once and stuff splattered, guess what? Then you should add more things as you go into the room the next time. Meaning, instead of just having gloves on for PPE, maybe you should add eye protection. I'm not kidding you. On some of these patients that have some illnesses or some serious problems with diarrhea going on, you just never know. Okay? So, please know that. Fecal incontinence is going to be defined as the inability to control the passage of feces and gas through the anus. This also affects the patient more emotionally than urine typically. The person may need bowel training, help with elimination after every meal or every 2 to 3 hours. Incontinence products to keep the garments and linens clean, and good skin care as well. So this is going to be an example here of charting bowel movement. So we don't actually get to chart at many of our facilities. I know at Ellsbury Healthcare Center, we're going to chart. There's a bowel movement log, and I'm going to show you guys that everybody's bowel movements get charted on. It just says the patient's room number, and you check mark if they have large, small, or medium. Okay?
If they don't.
What?
If they don't.
If they don't, then you don't check mark at all. Yeah, during your shift. So that's the only charting that you guys can do. Otherwise, you have to report bowel movements, urine, intake, and output completely to the nurse, vital signs, and so forth. You have to write it down and give it to them, okay, so that they can chart it. So you're charting here the color, the shape and consistency, if there was any pain with it, and the size of it as well. You need to get used to saying small, medium, or large for bowel movements. Flatulence is going to be the excessive formation of gas, where flatus is gas itself. The following help produce flatus are going to be exercise, walking, moving around in the bed in the left side lying position. Okay? Doctors could order enemas and drugs to relieve that flatulence, possibly. Bowel training, it has 2 different goals here. With bowel training is to gain control of bowel movements and is to develop a regular pattern of elimination. Factors that promote elimination or may help a patient with constipation should be included in the care plan and the bowel training program, and they could include increasing the fiber in their diet, increased fluids, warming fluids, activity, and privacy as well. Sometimes the shower or bath helps the patient have a bowel movement as well. A suppository. So most suppositories are medication, and so you're not going to get to insert a suppository, but you may watch one be inserted. So suppository is a cone-shaped solid drug that is inserted into a body opening. We use this Tylenol, can be a suppository. It doesn't look like a pill. The suppositories look like a wax small tampon, honestly. Okay, but they're basically wax, which is made up of the medication. You insert them again about 2 inches or so up the rectum with lubrication on it. Insert that, and it usually either a bowel movement or the medication is soaked up within about 30 minutes. So it's slower. But this could also cause a bowel movement to happen. Okay? We are not allowed to put suppositories in. Okay? Enemas, though, we are. Is there a lot of time and room for that at clinical? There's not. Most of the time, the nurse is going to do them because most of the time they order medication enemas called Fleet's enemas. But they could order a soap suds or a tap water enema, and you guys could have to do those. An enema is going to be the introduction of fluid into the rectum and the lower colon. The doctor has to order them to remove feces, to relieve constipation, to clean the bowel feces before a procedure like a colonoscopy or something like that. Then the doctor's they're not only gonna order the enema, they're gonna also order the solution that is done. The solution depends on the reason for it. A saline enema is going to be a solution of salt and water. Tap water is just straight from the faucet. Soap suds enema is going to be a solution of Castle soap and water. A small volume enema, this is probably going to be medication. It's going to be commercially prepared. There's also an oil retention enema, and others may be ordered. The nurse gives the enemas that contain drugs or medication. Cleansing enemas are going to clean that bowel and feces of any stool or flatus. They're going to relieve constipation and fecal impaction, and they are needed before certain surgeries and diagnostic procedures as well. Tap water enemas can be dangerous. They don't do them as much anymore. Normal saline enema solution is similar to body fluid, and then soap suds enemas can irritate the bowel mucus lining. So I really don't foresee you guys having to honestly go give any enemas. We don't even do a lab checkoff for giving an enema. But if you get to see one or get to assist with one, that I welcome you to go do that every single time, okay? But you do need to tell them that you haven't been shown to do it, okay? That you need to be shown how to do it. And if you're comfortable after one time of doing it with someone else, then you are welcome to do it as long as it's not a medication enema. All right, so this is going to be a picture here of how to give a tap water enema on picture A here, or the picture 2 on the screen on the left-hand side. So you always, when you're giving an enema, you should have the patient's left side laying down, and their right side leg should be up, and they should be laying on that left side. So then you insert a lubricated end of that, and that water is just going to flow out by gravity, okay? Hoping it slows it down a little bit. This over here is going to be a small volume enema, like a mineral oil enema that's pretty common. It's going to be inserted 2 inches into the rectum, and you squeeze that bottle and get every single ounce of that medication out and into the rectum, okay? And watch out. Put a bedside commode close by, okay? An ostomy. I think some of you might have saw one last year at Ellsbury Healthcare Center, but I'm not quite sure. It's down that right-hand hallway. Yeah. Might have saw this last year. We have a couple examples to show you in the lab. But ostomies are going to be surgically created openings for the elimination of body waste. These can be temporary, they can be full-time, they can be created because the patient had colon cancer maybe, they had Crohn's disease, part of their intestines died off or they needed to remove part of it, they created this opening, then maybe months to a year later they go in and close that back up. So they're not always permanent openings. But these openings are made so that the feces can escape and the gas can escape. So you have to attach a bag over top of the stoma to collect those things, okay? A colostomy, this is a surgical created opening between the colon and the abdominal wall. There's a permanent colostomy where the diseased part of the colon was removed so much that you're not going to be able to go back to that. A temporary colostomy gives the diseased or injured bowel time to heal, and you can go back later and have that close back up. The colostomy site, or where that stoma is located, is going to depend on where the injury is. Okay, so it could be anywhere. It could be on your right side, left side, lower, any part of that abdominal cavity where that intestines is. Okay. Also, the stool consistency depends on where the site is. The lower, the more formed it's going to be. The higher, it's going to be maybe just straight liquid that's coming out of the stomach. And it hasn't had time to go through all that digestive tract, your intestines, to make that formed stool. Okay. So this is a couple different examples of where stomas may be located here and showing you the part that had to be transected or cut into the opening. An ileostomy, this is going to be very, very close to the beginning of the stomach, so this is really going to be liquid stool. It drains constantly from an ileostomy. Okay, you're going to have constant drainage. Ostomy pouches look like the pictures here above. It's really nice when the patients learn how to change them out. They can talk you through it as well, and they do. They have an adhesive that goes around the stoma there, and then really they make it where the new pouch can just be changed out or emptied right there, and not the adhesive taken off every day, because that can really start to cause skin breakdown and so forth. Okay? Showers and baths need to be delayed for 1 hour to 2 hours after applying a new pouch to give that adhesive time to stick. Many of the pouches have a drain at the bottom, so you can just go in and drain that with your shift, or if it's got too much in it where it would be too tight, then you should drain that at any time. If it's bulging or anything like that, then you should go ahead and empty the pouch. Otherwise, the main pouch there is going to be changed every 3 to 7 days or when it leaks, and you should never flush pouches down the toilet. So that was chapter 29, and we're going to skip this video for now and move on to chapter 30 with nutrition. If you guys ever go into any medical programs at all, even you, those of you involved in animal care as well, you are going to have to take a nutrition class. Okay, this lecture isn't as long as the last two. It's more about just basic nutrition and so forth. It doesn't take us very long. So chapter 30 is nutrition needs. So again, I told you this picture was going to be in this lecture. Again, this is a picture of the GI system, starting at the mouth and ending at the anus. Dietary practices really depend on a lot of personal preferences, but a person's diet really affects your physical and your mental well-being. A poor diet and poor eating habits increase the risk for infection, increase the risk for acute and chronic diseases, cause chronic illnesses to become worse, cause healing problems, affect physical and mental function, increase the risk for accidents and injuries. Culture, finances, and personal choice really affect dietary practices. Okay? Nutrition itself is going to be the process involved in ingestion, digestion, absorption, and the use of foods and fluid by the body. Good nutrition is really needed for growth and healing and body functions. A well-balanced diet and correct calories are going to be needed for your everyday maintenance of your body. There are nutrient groups. They are broken down into fats, proteins, carbohydrates, vitamins, minerals, and water. A nutrient itself is going to be a substance that is ingested. That was a close one. Ingested, digested, absorbed, or used by the body. Fats and proteins and carbohydrates produce that energy for your body. What's that cellular energy called? What's cellular level energy called? It starts with an A. ATP. Good. The amount of energy provided by a nutrient is measured in calories, and a calorie is the fuel or energy value of food. Okay? In 2010, the dietary guidelines were set for patients 2 years and older, and they're really supposed to promote for patients to attain and maintain a healthy weight, to reduce chronic diseases, to promote overall health. And you might remember seeing this My Plate, the fruits, vegetables, grains, proteins, and dairy on the myplate.gov. Protein is going to be the most important nutrient. Honestly, it is needed for tissue growth and repair. Carbohydrates provide energy and fiber for bowel elimination. Fats provide energy. Vitamins are also needed for certain body functions, like you need vitamin D in order to absorb calcium. Minerals are going to be used for many different processes, and water is needed for all body processes. Okay, that's why it's important to drink your water. H2O. So food labels are used to make informed food choices for a healthy diet. Food labels contain a lot of information about the serving size, the calories, the nutrients, and how it fits into your daily allowed calorie intake, which is based on a 2,000 calorie per day diet. Meeting nutritional needs is a team approach. We should be discussing in your care plan the likes and dislikes of patients, the lifelong habits, religion, whether there's fasting or not, finances, and appetites like anorexia or illnesses like bulimia as well. Body reaction, drugs, and age should all be talked about. There may be a special diet order like a low sodium, low fat, a low sugar diet as well. The health team needs to consider this need for dietary changes, personal choice, and religion and culture. And a regular diet, though, means that they have no restrictions at all, no dietary limits or restrictions on their diet. The sodium-controlled diet are going to be those patients with heart problems, maybe kidney issues as well. The sodium can cause your body to retain water or cause that swelling on your body, and your heart has to work harder then. Sodium control decreases the amount of salt in the body, and we get way too much just on our everyday diets anyways. The doctor orders the amount of sodium allowed. The sodium control diets involve getting rid of high sodium foods, not adding any extra salt at the table, diet planning, and so forth. A A diabetes meal plan, we're looking for more consistency, balancing out our protein and our carbohydrates and our sugars so that our body properly knows how to use insulin. You should keep into consideration that you need to serve meals and snacks on time. A lot of people's diets or health issues depend on that. You should always check and see what was eaten and write down the percentage. You should report what the patient did and did not eat and report any changes in their eating habits. If you ever hear the term dysphagia, difficulty swallowing, we have a lot of patients with this, and they may need their foods thickened or drinks and stuff like that because you don't want them to aspirate or choke. If you're feeding a patient with dysphagia, you should watch and look for signs of choking and coughing or difficulty breathing. You should slow down with the patient that you're having to feed and follow aspiration precautions, making to set them up nice and big and tall. They don't use a straw, and they're probably going to have thickened liquids. Next week, we're going to be thickening some liquids that we just have here in our class. So Nectar Thick is going to be the thinnest thickener here. It's still a little bit liquidy, but a little bit thickened. Honey Thick is the consistency of honey, and then Pudding Thick, of course, is the thickest consistency that the patient could need with eating. So the following can affect appetite and ability to eat. This is weakness, illness and confusion, unpleasant odors, sights and sounds, an uncomfortable position, the need for oral hygiene, the need to eliminate, and pain as well. Preparing for meals, you should assist with eliminations needs as possible, provide oral hygiene, make sure that their dentures are in place so that they can eat. Serving meals, make sure that you are doing them in the assigned order, that if the food is not served within 15 minutes, you may have to reheat it. And the elderly really like their food to be pretty hot and warm when it's served to them. Otherwise, they're going to ask you to take it to the microwave to reheat it. When feeding a patient, if they are blind or visually impaired, you could use this clock system to tell them the location of their foods because maybe they're able to feed themselves but they're visually impaired. Looking up here real quick, you could say the potato is at 12, the vegetables are at 3 or 4, your protein or meat is at 6, and your bread there is at 9. So that is giving them a visual image without them having the visual capability of seeing the food on their plate. If you have a visually impaired person that you are feeding, then you should tell them everything before they eat it. I like to tell the patients when I'm feeding them, even that are not visually impaired, what they're getting ready to eat. Okay? You should use a small spoon to feed the patient, offer fluids during the meal, and so forth. You should also allow time for prayer, engage the patient in a pleasant conversation, allow for time for chewing and swallowing, even if you're in a hurry. You got to go feed another person. You got this, you want to go home. Blah, blah, blah. That's not fair to the patient. Okay? You should always sit facing the patient. You can see how well the patient is eating that way, and you can also see if the patient has problems swallowing. These are going to be some modified devices for patients that have had strokes and other disorders and so forth. So the coffee cup down here has 2 handles. Those utensils up there are modified for the patient. And then this is kind of like a plate where the plate doesn't slide from the patient. Maybe they only have one limb to eat with. And so you can't imagine only eating with one hand. I mean, that seems like it would be easy, you guys. But honestly, it's a little bit hard when the plate is sliding. Also, you might be providing between meal nourishments like snacks and so forth, and you also need to keep track on how much the patient is eating in calorie counts. This slide is one of the most important things you need to pay attention to before clinical because you have to do this on your state testing, but you also have to do it at the clinical site. If you collect a tray, whether it's breakfast, lunch, or anything like that up, and you're taking all the trays up, you have to give a percentage of how much the food the patient ate. So, looking up your example, the patient ate no food, 0%. The patient ate a few bites of each, so 25%. This is 1/3. That's one that we don't document a whole lot, 1/3, but we really like to do 25, 50, 75, and 100. Okay? But if you really feel like they need a little bit more credit than 25, and it's not quite half, then you can give them 33%. That's fine. Okay? 50% of their food down here. 75% of their food, and then 100%, of course, they clean their plate. Okay? So you have to document and let the nurse know exactly the percentage of the food that the patient ate. You also have to document how much the patient drank in meals. You should also provide drinking water with each shift and whenever the pitcher is empty. If you're looking for something to do, I'm always going to tell you, go fill ice waters every time. You should not be sitting down at clinical ever. You're there for 2.5 hours. There really is not that much opportunity to sit down. I know in the afternoon there's more than in the mornings, but anyone doesn't need to be sitting down. You can find things to stock. You can go refresh in ice waters and so forth, okay? Foodborne illnesses, so these are going to be food like salmonella, E. coli, and so forth. You need to make sure that when you're preparing foods that you're washing your hands, that foods that are supposed to be hot stay hot, that they don't get too cold, that they're not out for too long. You should report any signs and symptoms to the nurse at once. So washing hands is important when you're getting food prepared and so forth, and avoiding cross-contamination of uncooked foods is going to be important with foodborne illnesses. This is going to be the temperature zone that food should be cooked at. And lastly is a procedure here on feeding a resident. And I'm going to wait to show you this until we go in to feed a patient. Okay? Alright, so you guys have about 10 minutes left or so. I would like for you guys to work on your workbook